Yes.
Afternoon everyone, I am Dr. Pratik. In today's topic, first of all, I would like to thank Dr. Sandeep for this today's initiative of this respiratory workshop cum presentation. So my topic is oxygen delivery device. So this topic is mainly bit more informative and descriptive. So I would like to go bit a summarized form of the slide. First of all, the indication of oxygen therapy. So indication of oxygen therapy is hypoxia. By definition, when PO2 partial pressure of oxygen less than 60 or saturation less than 90% in room air, or the primarily low PO2 of less than 60 or saturation less than 90. In neonates, PO2 of less than 50 or SaO2 less than 88% or capillary oxygen tension less than 40. The common indications are low ambient oxygen, hypoxemia, suspected hypoxemia that in case of increased work of breathing, flaring. The clinical symptoms are increased work of breathing, flaring, tachypnea, increased myocardial work and acute head injury. So there are the common goals are to treat hypoxemia, to decrease work of breathing and to decrease myocardial work. The factor which will determine how or through which system we can provide oxygen are patient comfort, level of FiO2 needed, the requirement of the FiO2 be controlled with certain range, the level of humidification or nebulization, minimal resistance to breathing and efficient and economical use of oxygen. So there are two types of oxygen delivery methods there. Low flow oxygen delivery, it is variable performance and patient dependent, and high flow delivery system is a fixed performance device and patient independent. So high flow consisting of venturi mask, mechanical aerosol system, high flow humidifier system, and low flow nasal cannula, simple mask, nasopharyngeal catheter, partial rebreathing mask and non-rebreathing mask. So first of all, as per the definition, in room air PO2 should be less than 60. Then we can start oxygen. So we have to calculate the PO2. So PO2 calculation is like the following formula: FiO2 into barometric pressure, and that is 760, minus water vapor pressure 43, minus partial pressure of carbon dioxide by respiratory quotient is 0.8. So in the room air it is PO2 with the standard calculation should be 100. With the FiO2 of 0.5, the PO2 will be 306, and FiO2 of 0.8, PO2 will be 520.
Sorry, that will be P capital AO. Because the PaO2 as an arterial oxygen is what we measure on the gas station.
Yeah, exactly. It's a PO2, right? Yes, sir. Right. Alveolar, right. So this is the oxygen hemoglobin dissociation curve. So we all know that this graph, it shows the affinity of oxygen with the percentage with this graph we can able to see the percentage of hemoglobin saturation with the oxygen concentration. So more this graph gets shifted to the right if we have rising in the temperature, rising in the carbon dioxide in the arterial carbon dioxide level, and increase 2-3 dpg level. So if low pH, rising temperature and rising PCO2 can causes this oxygen hemoglobin dissociation curve to the right side, it means there will be less affinity for the hemoglobin with the oxygen. So it causes increased release of oxygen to the tissue level. One more information that why we want to avoid 100% oxygen unless it is fully indicated, as because this 100% oxygen for a long period of time can causes denitrogenation and ultimately it causes resorption atelectasis. So this is the formula for oxygen delivery. I will not go into the details, but so oxygen delivery is depending on cardiac output, partial pressure of oxygen, hemoglobin and oxygen saturation. So now how to calculate FiO2 through different mode of oxygen delivery device with the nasal cannula, and though I will describe in details in my next slide how about the individual devices. So usually in nasal cannula, if we give 1 liter of oxygen, then the FiO2 will be 0.24. In that it can be increased. In oxygen mask, if we give 5 to 6 liter of oxygen, the FiO2 will be 0.4, 6 to 7, 0.5 in that way. And if we use any reservoir, then the amount of with our targeted FiO2 will be more. Low flow oxygen delivery system. It is stable. We can use this low flow system where the patient have stable delivery and breathing pattern, and the standard respiratory rate is less than 20, and normal inspiratory flow is there, and targeted minute ventilation less than 8 to 10 liter per minute. So in nasal cannula and nasopharyngeal catheter and nasal, there is no capacity. A very small capacity in nasal mask and simple face mask, and high capacity is there in partial rebreathing mask and non-rebreathing mask. In nasal cannula is a simple plastic tubing with a prong that over the ear adjustment. It can be adjustable for the size, can be adjustable as per the adult or children, and FiO2 can be increases with the per liter, we can increase by 4%. But if it is the flow required more than 5 liter, so this is not preferable. So this is inexpensive, well tolerated, and patient can able to eat, drink, and it is sometimes used for the COPD patients. And the problems are, it can causes pressure sore, crusting, dryness of the mucosa, epistaxis, and there are too much of oxygen wasted. Next, nasopharyngeal catheter. It's a soft tube, the size between 8 to 14 French. Catheter to be well lubricated and inserted into the patient's nose to the depth equal to the distance from external nares to the tragus, and the tip should be just above the uvula. And in that cases, oropharynx act as an anatomical reservoir. Problems are less popular due to DNS or any local problem like any mucosal edema, DNS, and sometimes patient incorporation due to gag or cough on insertion, incorporation, and nasal obstruction, sinusitis, skin irritation are potential complications. Nasal mask. It's a hybrid of nasal cannula and face mask applied by either, and over the ear there should be a strap, and then the lower end rests on the upper lip covering the external nose. So this is comfortable. The problems are, it can cause sore on long term. So this is the images of nasal mask. Now the simple face mask. It's a simple or non-reservoir oxygen-free mask. Is a disposable device. So the oxygen flow must be run at a sufficient at least 5 liter per minute or more to prevent rebreathing of the exhaled gases, and this is best suited for those who require more oxygen than the nasal prong. Oxygen therapy for short period like is usually when we require a short period of oxygen therapy, mainly in the post-operative period or during transportation. So this is lightweight, simple, and FiO2 we can give up to 0.5 we can achieve, and there we can be used with the humidity. Problems are when the patient need to remove it for speaking, drinking, or any expectoration of cough, drying. It can causes dry eyes and uncomfortable when facial burn, trauma, application problems, like when to put Ralph's tube we need to insert Ralph's tube. So this is in that case there is oxygen inlet, open port for exhaled gases, and air entrant through ports if oxygen flow through does not meet the peak inspiratory flow, and we can achieve up to 55% of FiO2 with 6 to 10 liter of oxygen per minute. Next is the reservoir mask. There are two types. one is partial rebreathing and one is non-rebreathing. Both are disposable, lightweight, transparent plastic. The difference are the placement of the valve in between the mask and the back and over the mask. Partial rebreather, part of a patient expired air refilling the back. In that case, some part of the air get into the reservoir back. So this is the partial rebreathing mask. First of all, oxygen get directed into the reservoir, and during inspiration, oxygen get drawn from the back, and some part of the exhaled gases goes into the back. So it's a so that's why this is partial rebreathing, where we can get fresh oxygen as well as some part of the expired air. So up to 60% FiO2 can be achieved. So this is the diagram. Now the non-rebreathing mask. Sufficient flow of oxygen is used to the reservoir back is at least partially full during inspiration. So minimum flow should be 10 to 15 liter per minute, and target FiO2 up to 100% with 50 liter of oxygen. So either style of mask, so both either partial rebreathing or non-rebreathing we can use for persistent hypoxemia with relatively normal spontaneous respiration. Now so this is the diagram. So air entry from the inlet to the reservoir, and from there during inspiration patient get inhaled from the back, and there is a valve which prevent the backflow of the air to the reservoir, and there is a expiratory one-way valve through which the expiratory gases can exhaled out. So the advantages are delivery of FiO2 more than 0.6 to match the moderate to severe hypoxemia, and the problems are insufficient flow rate may lead to rebreathing of carbon dioxide and claustrophobia, dry eyes, irritation, and sometimes uncomfortable to the patient. High flow oxygen delivery. So patient with variable ventilatory level and breathing pattern, profoundly dyspneic and hypoxemic, and for those who require constant high FiO2 and with late inspiratory flow of gases. So types are Venturi mask, face stent, aerosol mask, tracheostomy collar, TPs. So what is Venturi effect? Venturi effect is based on Bernoulli's principle. As the velocity of fluid increased, the pressure exerted by the fluid decreases. It can apply on both liquid and gases. So Venturi's principle describes how a second fluid can be entrained into the stream of first fluid. So this is the when when we have a from the larger cross sectional area, when there is a sudden narrowing, so then again it get increased in the cross sectional area, so there is a vacuum formation, and it causes and that vacuum need to get filled with the air from outside. So this is the Venturi effect, and with this effect, so like this, the oxygen get entrained, and suddenly there is the loss of pressure. Then the external air get filled up to fill up the vacuum. So this is the Venturi principle. So with that principle, we have the Venturi mask. The goal is to create an open system with high flow about the nose and mouth with a fixed FiO2. Oxygen is directed by a small bore of tubing to a mixed jet. Final concentration depending on the ratio of the air drawn to the entrainment port. Due to high flow, excess gas flushes out the expired CO2 through the holes on the side of the mask. So this is good for those with hypoxemia cannot be controlled with low FiO2. So this is the exhalation port. So this is the diagram. So this is the Venturi mask with the system. So you can see that there is a different color coding with targeted flow and percentage of FiO2 that can be achieved. So this is the chart. So blue we can achieve up to 0.24 in that way. So this is depending on the amount of oxygen we can provide, we can have our targeted FiO2. So as per our targeted FiO2, we can use that type of Venturi mask. So this is the ratio, entrainment ratio. Like for Venturi mask, if we need 0.24 FiO2, so the ratio will be 1:25. It means if we provide 1 liter of oxygen, then from external sources we have another 21 liter of air from the it get entrainment in that way. So so like if we give 4 liter of oxygen, then the total flow would be 140. It means that per minute the rest amount should be from the air in that way. So more of the FiO2. So accordingly we have to, so as per the in different types of Venturi mask, as per the color code mentioned with the targeted, so accordingly we have to give that much of oxygen flow to get targeted FiO2. Next is the back valve. So this is we all know that it's a self-expanding bag. Is called AMBU bag with an oxygen inlet and reservoir. So this is mostly used during anesthesia and or before any elective intubation. So this anesthesia bag is a non-self-inflating reservoir with the gas inlet and valve. Masks are designed to provide comfortable leak-free seal for manual ventilation. Flow to the reservoir should be kept high so bag don't get deflated substantially. And this device have the potential for a constant FiO2 of more than 90%. Problems are breathing percent flow has to be adjusted with the valve, and there are chance of aspiration, and constant adequacy of the flow of the gases need to be maintained. So this is the mass we need to fit here, and there is a this is the bag, and there is and this is the reservoir, and this is the valve is called non-rebreathing valve. Next is the air entrainment nebulizer. Large volume, high output, all-purpose nebulizer provide bland mist therapy with some control of FiO2. Commonly placed on patients following extubation for their aerosol producing property. Nebulizer system can be applied with many devices: aerosol, tracheostomy dome, collar face, tent, T-piece, adapter. If T-piece is used, if visible, mist disappear during the inspiration, the flow means inadequate. Excess water may collect in tubing and may obstruct and develop resistance to flow. Sometimes bronchospasm may occur due to irritant nature of sterile water. So this is the air entrainment nebulizer. Is a type of this is an aerosol mask. It can deliver up to 100% of FiO2 depending on the nebulizer setting. The flow rate should be 8 to 15 liter per minute. In pediatric, there are different types. One is the oxygen hood is there. This is the oxygen hood, oxygen tent. So this is the image of the oxygen tent, where we can have transparent enclosure in larger size for the adult, and carbon dioxide is removed by soda lime and water vapor by calcium chloride. Temperature is regulated by flowing oxygen and in air over ice. Up to 70% of oxygen concentration can be achieved by the flow rate of 10 to 12 liter per minute, and the air changes should be 20 times per hour. Problems are isolation and confining. FiO2 can be vary from 0.21 to 1%, and the risk of fungal infection. So there are some other devices like phase tent. It can provide up to 40% depending on the nebulizer setting. Flow should be up to 15 liter, and mainly used for those who cannot tolerate a mask. So now if I open for any questions or any discussion. Thank you.
Pratik, some doubts. First of all, I'm not very clear about which one to use, which one not. It would have been better if you can explain in a kind of tree format which one is better to use. Second, which one is best for transport purpose? Suppose you are transporting patient on ground or on air. Is there any preference of such thing?
Like,
and my third question is how we are going to understand that it has to be changed because many times that has an implication on the costing as well. So
Okay.
what is the lifespan of these?
Okay, the first query, for which person we can have look, we have two type of, one is the low flow device and one is the high flow device. So I have mentioned in the low flow device there are, this is the definition. So low flow device depending on patient. So if the patient is on spontaneous breathing and there is no signs of respiratory distress like tachypnea, nasal flaring, so in that case we can start with the low flow device depending on the oxygen saturation, depending on the oxygen requirement. So like low flow start with the nasal cannula, so it is all depend on the clinical scenario, number one. And those who require high amount of oxygen, more than 8 to 10 liter of oxygen, still is not able to maintain the target oxygen saturation. In that case we have to go for the high flow devices, as because this is patient independent, number one. And second thing is during transport, depending on the patient, if the patient is on spontaneous respiration, one thing. If the patient is on any positive pressure ventilation or intubation, depending on the patient scenario. If patient can tolerate spontaneous breathing, then we can start with the low flow. But if any patient on definite airway or requiring already on NIV, so for those patients we need some, depending on the patient scenario, we have to target our choice of instrument for during transport. And the duration usually duration of what our
use of this mask, what is the life? When we understand we have to change this mask.
Actually is all are disposable, is particular for one single patient, one item for one patient. And third thing, there is no access, there is no clean cut that we have to use this thing for this particular days. It's all as per the logistics. Like if it get blocked, like if the mask get blocked, or if we use that breathing mask, and that if the bag is not working properly, or if, then I think we have to change. Otherwise there is no that much
So
any
this also
timeline.
can work as a secondary infection for the patient.
Exactly. So that's why if there is any contaminated, if we are not able to give, if they get blocked, then we have to change. Otherwise there is no rule, or there is no definite timeline is there, I think. So we have to start with the low flow device if the patient is on spontaneously breathing, and then we have to assess the situation. Still, if the low flow devices, if the patient is not able to maintain the target saturation level, or still patient becomes symptomatic, then we may need to change to the high flow system. We are only looking after the hypoxia part, as because there are some specific scenario where too much of oxygen is not required. In that cases we have to titrate the oxygen delivery and mode of devices depending on the patient clinical scenario. But altogether our basic target of this slide to how we can give oxygen to the patient. So, but not all the patients require only oxygen. Some patient there are some patients who require less amount of oxygen, like mainly for COPD patients. So in that case we have to adjust and we have to titrate the supportive instrument as per the clinical scenario. So this is mainly how we can give oxygen. This is just a schematic and informative description of the individual instrument and its merits and demerits. But clinically we have to judge the patient as per the clinical scenario, as per the arterial blood gases, PO2 level, PCO2 level, and accordingly we have to plan. Anyone, any queries, anything you want to ask?
I just wanted to make a few comments only for the residents here, actually.
Yes, sir.
Firstly, I'd like to congratulate you guys for doing this program on oxygen delivery, because আমরা অক্সিজেন থেকে কিন্তু হালকা ভাবে পাইপে করে চলে আসে যে কেউ লাগিয়ে দেয়, বাট অক্সিজেন ইজ আ ড্রাগ, যে কোনো ওষুধের মতো তার একটা ডোজ আছে, কার লাগবে কার লাগবে না, এটা কাজে তো ডেফিনেটলি দেয়, ক্ষতিও করতে পারে। Pratik mentioned that 100% oxygen given for prolonged periods can cause problem. COPD patients এ যদি excess oxygen দেওয়া হয় তাহলে it can cause problem, জানতে হবে, দরকার হলে দিতে হবে। device selection is very important. কিন্তু আমরা কি টার্গেট করছি? See, আমরা যখন চায়ে চিনি 1 চামচ দিলাম কি 2 চামচ দিলাম কি 3 চামচ দিলাম, চাটা মিষ্টি হওয়া নিয়ে কথা। এই মিষ্টিটা হচ্ছে স্যাচুরেশন। চায়ে চিনি কতটা দিলাম সেটা হচ্ছে পিওর। PO2টা আমরা kg করে মাপছি, but what we are interested in is the saturation. Saturationটা ওই 92 or above at least হতে হবে. That is the amount of oxygen that is required. If anybody is hypoxic, they need oxygen. তারপরে অন্য কিছু করতে হবে। The other thing is the saturation আমরা মাপি pulse oximeter দিয়ে নর্মালি ICU ওয়ার্ডে। PO2 মাপি আমরা ABG করি। বুঝতে হবে যে ABG করেছি PO2 খুব ভালো আছে, কিন্তু স্যাচুরেশনটা গন্ডগোল আছে। এই যে পালস অক্স দিয়ে আমরা যে স্যাচুরেশনটা মাপছি, it is also dependent upon the perfusion. যে কারোর যদি হাইপোটেনশন থাকে, যে শকে থাকে, তার লাং খুব ভালো আছে, তার অক্সিজেনেশন খুব ভালো আছে, কিন্তু সেই অক্সিজেনটা ব্লাডটা ক্যারি করছে না টু দ্য টিস্যুস, ব্রেনে স্যাচুরেশন কম হয়। সুতরাং স্যাচুরেশন কম মানে এই নয় যে অক্সিজেন আরো বেশি দিতে হবে, তুমি ম্যাক্সিমাম অক্সিজেন দিয়ে রাখতে পারো, but you also have to take care. That is why we say it is ABC. The purpose of oxygenation, what Pratik mentioned, is oxygen delivery. And at the end of the day, lungta shudhu blood oxygen delivery hobe na, ওই অক্সিজেনটা deliver hote hobe. So if your blood pressure, that depends not only on the PO2, but also on the hemoglobin and also on the perfusion, carrying out blood pressure, etc. And a device, the main difference. And the patient who অসুস্থ, transport, etc., you give as much as possible. Because transport is a finite. I mean, ঘন্টা নিয়ে গেলাম, সিটি করে নিয়ে এলাম, একটা এই হসপিটাল থেকে ওই হসপিটাল গেলাম, একটু বেশি দিলে ক্ষতি নেই। বেশিরভাগ দেখবে অ্যাম্বুলেন্সে পেশেন্ট আসতে দেখবে রেজার্ভার মাস্ক নিয়ে আসে, সেটা সমস্যা করতে পারে না তা, CO2 রিটেনশন হয়ে যেতে পারে COPD পেশেন্টের, কিন্তু ওই পিরিয়ড গুলো ঠিক আছে। দেন ইউ টেক কেয়ার অফ দি ডায়াবেটিক। যেটা হচ্ছে এই যে লো ফ্লো ডিভাইসেস, যে নেজল ক্যানুলা, যেটা খেয়াল রাখতে হবে। I mean, that mathematical যেটা ওটা এত লিটার দিয়ে এত FI টু জেনারেট করবে, দ্যাট ইজ ওকে ফর সর্ট অফ বেসিক আন্ডারস্ট্যান্ডিং। বুঝতে হবে যে আমি যখন শ্বাস নিচ্ছি, আমি ধরো মিনিটে 15 বার শ্বাস নিচ্ছি, 20 বার শ্বাস নিচ্ছি, 20 বার শ্বাস নিলে একটা রেসপিরেটরি সাইকেল ইজ 3 সেকেন্ডস, ঠিক আছে? 23 আর 60, 3 সেকেন্ডের মধ্যে হয়তো 1 সেকেন্ড হচ্ছে ইন্সপিরেশন। আমার নরমাল টাইডাল ভলিউম কত? 500 ml। তাহলে 1 সেকেন্ডে আমি 500 ml এয়ার টানছি, তাহলে ওই ফ্লোটা কত? ইট ইজ अबाउट 30 লিটারস পার মিনিট। আমি যে 2 লিটারস অক্সিজেন দিচ্ছি নেজাল ক্যানুলায়, তার 2 লিটারটা অক্সিজেন আমি কিন্তু টানছি 30 লিটারস পার মিনিট। তাহলে বাকিটা কি হচ্ছে? বাকিটা হচ্ছে বাতাস থেকে মিশে ঢুকছে। সুতরাং FiO2টা কি পাবে পেশেন্ট, সেটা নির্ভর করছে অন দ্য পেশেন্টস রেসপিরেটরি প্যাটার্ন। আমি যদি ধীরে ধীরে ডিপ ব্রেথস নিই তাহলে অনেক অক্সিজেন পাবো। আমি ভাবাচ্ছি, যখন আমার ইন্সপিরেটরি রেট আরো বেশি, তখন কিন্তু অক্সিজেন অনেক কমে যাবে। সো one of the advantages of a nasal cannula or a simple mask is it is more comfortable. Patient can buy is not claustrophobic. কিন্তু problem হচ্ছে যে you cannot measure how much FiO2 patient is getting. I think nasal cannula দিয়ে 4-5 লিটারের বেশি দেওয়া যায় না, which you have mentioned, at least all this crusting and dryness. The same with the simple mask. এটা দিয়ে আরেকটু বেশি দেওয়া যায়। খেয়াল রাখতে হবে, অনেক সময় বডি দেখি যে মাস্ক লাগানো আছে কিন্তু পেশেন্ট 2-3 লিটার অক্সিজেন পাচ্ছে, সেটা কিন্তু ঠিক না, কারণ এই মাস্কের একটা ভলিউম আছে যেটা নেজাল ক্যানুলা নেই। সো ইট ক্যান কজ CO2 রিটেনশন, পেশেন্ট যেটা ব্রিথ আউট করছে, unless the flow is high. So একটা নরমাল মাস্ক লাগালে 5 লিটারের কম অক্সিজেন কিন্তু দেবে, 5 লিটার বেশি দেবে, so that the CO2 that the patient is breathing out gets washed out. এবারে একটা COPD পেশেন্ট, তার একটু হাইপক্সিয়া আছে, তার স্যাচুরেশন 85 হচ্ছে, আমাকে তাকে অক্সিজেন দিতে হবে। আমি যদি তাকে খুব বেশি অক্সিজেন দিই, তার হাইপক্সিয়াটা কারেক্টেড হবে কিন্তু তার CO2 রিটেনশন চালু হবে। So you need to give the minimum amount of oxygen necessary to maintain the level of saturation that you require, which is about say 90-92% in a COPD patient. সেখানে তোমার এই ইভেন্চুয়ালি ডিভাইসটা ইউজ করতে হবে। এই বিভিন্ন ডালগুলো সবসময় পাওয়া যায় না, কিন্তু বডি যেটা আছে ইজ আ ভ্যারিয়েবল ভেন্চুয়াল। এটা একটা মাস্ক পাওয়া যায় সবুজ রঙের আছে, দুটো খাপ থাকে, একটা সাদা একটা সবুজ, ওটাতে 24, 28, 35 এবার পেশেন্ট ব্রিথ করছে, আমরা তো 500 ml ব্রিথ করছি কি 400 ml ব্রিথ করছি, ওই বাতাসটা কিন্তু ওই রিজার্ভয়ার থেকে আসছে। ওই রিজার্ভয়ারে কি আছে? এয়ার নেই, দিস অক্সিজেন। দ্যাট ইজ ওয়াই ইউ আর জেনারেটিং হাই FiO, বেশি অক্সিজেন। কিন্তু এই সি এর প্রবলেম যেটা হচ্ছে যে देयर इज নো গুড সি, কিন্তু কিছুটা ডাইলুশন হয়, কারণ এই মাস দিয়েও 60-70 এর বেশি পাওয়া যায়। আর এটাতে যদি অক্সিজেনেশন না মেইনটেইন করে তাহলে কি হবে? Okay, so basically there are two things that control আমাদের শরীরে অক্সিজেন কতটা ঢুকবে। একটা হচ্ছে FiO, তোমার FiO কত? হ্যাঁ, FiO মানে কতটা অক্সিজেন তুমি শ্বাস নিচ্ছ? 21%. So এই যে 24%, 28%, 35%, 40% মানে আমরা বাতাস যেটা টানছি তার অক্সিজেন পার্সেন্টেজটা পাচ্ছি, কিন্তু তুমি ম্যাক্সিমাম পার্সেন্টেজ দিয়ে দিয়েছো এই মাসটা আসতে। তাতে যদি না হয় তাহলে তোমাকে প্রেশার বাড়াতে হবে। দ্যাট ইজ দি সেকেন্ড থিং। সো প্রেশার বাড়াতে গেলে তুমি সিরাপ দিতে পারো, এনজেফেনল দিতে পারো, বা ইনকিউবেট করে ভেন্টিলেট। সো এই ডিভাইসেস গুলো দেখতে হবে, ডিভাইসেস গুলো বুঝতে হবে, আর এটাকে ওষুধের মতো ভাবতে হবে যে আমি কতটা দিচ্ছি, কি ডিভাইস দিচ্ছি, কতক্ষণ দিচ্ছি, আর আমার টার্গেট রিচ করলে আমি কমাবো হবে সেটা you have to decide. ওটা র্যান্ডম এর উপরে ছেড়ে দিতে হবে। Thank you, Pratik. Sorry, I just
No. Thank you, sir.
This is a topic which is very close to my heart.
Thank you, sir. And because sometimes we get confused that oxygen delivery is not the oxygen is not the is a type of is a drug. Like in ICU we have many drugs, and oxygen is a drug. Like for IV we have there are different types of drug we know. It may be through oral route, it may be through IVM in that way. So this is the route through which you can give a drug called oxygen to the body. Okay, and then beyond it, when I have mentioned few instruments which is not here in the slide, like HFNO, as because then it's not only about the drug, it's not only about the oxygen, it's about the whole respiratory system. Okay, so this is how we can give oxygen. So this is the different types of, and স্যার যেটা বললেন যে আমরা এইগুলো দিয়ে অক্সিজেন দিতে পারি। প্রত্যেকটা যেগুলো ব্যবহার করা হয় আমরা দেখতে পাই অনেক সময় আইসিইউতে যে মাস্কে দেওয়া হচ্ছে অক্সিজেন দেওয়া হচ্ছে 2 লিটার, আমরা হয়তো অক্সিজেন কমাতে বললাম, সে মাস্কেই পেয়ে যাচ্ছে 2 লিটার 3 লিটার করে। তখনই যে মুহূর্তে একটা পেশেন্ট 4 থেকে 5 লিটার অক্সিজেন পাচ্ছে মাস্কে, আমরা তাকে বললাম অক্সিজেন কমাও, তখন কি করতে হবে? মাস্কটাকে চেঞ্জ করে ক্যানুলা করে দিতে হবে। ম্যাক্সিমাম ক্ষেত্রে দেখা যায় আর ক্যানুলা ইন্ডেন করা হয় না, মাস্কেই চলছে। কী প্রবলেম হবে? আমরা যেটা আলোচনা করলাম, যদি মাস্ক দিয়ে দেওয়া হয় তাহলে CO2 রিটেনশন করবে। কেন করবে CO2 রিটেনশন? লাস্ট কোশ্চেন, কেন করবে? মাস্কে কম অক্সিজেন দিলে কেন CO2টা রিটেন করবে? কেন? এটা যে বুঝতে পারবে আমি জানবো তাহলে আমার কাজটা সাকসেসফুল, নাহলে কিন্তু আমি ফেল। হ্যাঁ, তাহলে কি হবে? হ্যাঁ, মানে স্পেসিফিক শব্দটা কী হবে? কেউ একটা বললো মনে হয়, কে বললো এটা? গুড। So this is, so we have to give oxygen as much as to avoid rebreathing. For nasal cannula, our own nasopharynx is a reservoir, natural reservoir. So basic কত অক্সিজেন দেবো, স্যাচুরেশন কত আছে, আর যেন রিব্রিথ না করে। So this is the basic thing. আর অক্সিজেনটা পেশেন্ট নিতে পারছে কিনা। So this is the few things more. Thank you.